So we're expected to deal with all of these assets, which are subject to inflation. But actually, we're in an environment where if we're dealing with a government payer, we're experiencing deflation. Our value has gone down.
Oh yes. It is challenging, and one of the things that this clinic has attracted the attention of some corporations who are happy to partner with me
Yes.
to try and do this. And that has been a saving grace because the medications, the technology, I would not have access to that if I didn't have those partnerships. And it is incredibly valuable.
Welcome to UPMED, a journal of healthcare's race to the bottom, hosted by Dr. Kecia Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Hello to our listeners, and welcome to another chapter of UPMED, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Rowe Urquhart, and I am here with a dear friend of mine who is also a physician, Dr. Kecia Ford. Welcome, Dr. Ford.
Thank you. Thank you for having me.
For our listeners, I just want you to know that Dr. Ford is a very esteemed internal medicine doctor who has tremendous qualifications. She, like myself, has a Bachelor of Science degree in biomedical engineering. Her degree is from Duke University. She also then went on to pursue a master's degree in, of all subjects, physics. After that, she decided to pursue a Doctor of Medicine, an MD, and attended the University of Medicine and Dentistry here in New Jersey. Dr. Ford, welcome.
Thank you. Thank you. Wow.
Dr. Ford, I wonder if you might share a bit about how you came to that decision, especially having pursued the degree in physics, how you came to the decision to pursue a career in medicine.
Well, that is a wonderful story that I'd love to share with you. I have always been interested in technology. I think what inspired me actually was the Jarvik 7. I'm probably dating myself, right? The artificial heart, the Jarvik 7. When that came into being, it sort of captivated me. And I hadn't gone to college yet, but I knew I was going to be a biomedical engineer because that's what I wanted to do. I wanted to build the next heart or and ironically getting the degree while I was getting my degree, I decided to try working in the industry first. So I worked as a biomedical engineer and I was living my dream. I was building medical equipment. And in the process of doing that, I got the master's degree in physics because it was helpful to the equipment that I was designing at the time.
Can I just interrupt for a second?
Sure.
You're the first person I've ever met who said they got a master's degree in physics because it was helpful.
Yeah. Well,
I mean, that kind of belies your intellect. We're talking to someone who should be a member of Mensa. Come on. Oh, yeah. And by the way, yeah, I got a master's in physics because it would be helpful. I'm
that's
sorry, I
okay. That's
interrupted. Go
okay.
on.
I was part of my job at the time as a biomedical engineer, I was working with lasers and I knew so little about it that I started taking some courses just to help me do better at my job. And I got so far in, I was only a few courses away from the master's that's really how it happened. And then, so I've always had 2 feet one in science and one in medicine for as long as I can remember. After my job moved away, I didn't want to move. I couldn't move. I was newly married at the time. And so I applied to medical school. And I got my degree with the idea really of still doing a little of both, designing medical equipment. I wanted to build the better next thing. And I didn't know exactly what I wanted to do. So I went into internal medicine as that first step because that was going to be my residency.
Yes.
And I have to credit my residency training advisor. She was the chief of our program, Dr. Joanne Rateguez, with opening my eyes to medicine as both an art and a science, and most importantly, a service. And I actually asked her to write a letter for me because I was looking at doing different fellowships. And she actually said to me, she said, we would suffer a great loss if we lost you to specialty medicine because you have a gift for treating patients in primary care. It's treating the whole patient and then understanding their needs and getting them to the right place.
Yes, so this is a great throughput. I'm going to fast forward then some 25 years and ask you about, because we did touch on briefly your background in technology, medical technology, and my biomedical engineering. I really looked at biochemical engineering and was thinking more along the lines of biotech. But you're really speaking about biomedical engineering with regard to the instrumentation and the use of technology in a practical sense, physical
Absolutely.
sense
Hmm.
in medicine. And so, if we fast forward now, your practice is in, and I'll let you describe what this means, a federally qualified health center,
Yes.
and you have patients in high risk conditions, high risk clinics. And I'm wondering if you can speak a bit about number one, what an FQHC is, and then number two, about these patients and how they're benefiting from technology.
Okay. So, a federally qualified health center is actually, I work for Joseph Piadabo Family Health Center. We have offices in medically underserved population areas of New York. And I run a high risk diabetes clinic within that office. And what happens is we basically have patients who usually have diabetes, hypertension, and hypercholesterolemia. And I have been able to use technology to help reduce their risk factors for complications and keep them as healthy as possible.
Yes, yes. And so let's drill down a bit with regard to these technologies because many of them were not accessible 10 years ago.
True.
I personally have experience with the continuous glucose monitor. That's something you can get even if you don't have diabetes, and it gives you real time information about your blood sugar. So I learned that a banana could make my blood sugar go from 60 to 120 in 5 minutes.
Right.
And I never would have known that
Right.
without the CGM, the continuous glucose monitor. Can you tell me a bit about these wearables and other technologies that have really improved your ability to treat diabetic patients? Diabetic patients, you might want to speak a bit about too what that means exactly.
Right. Right. Well, as you said, the technology, the wearables, we use Dexcom and the Freestyle Libre primarily as the glucose monitors in the clinic that we use. And it is very empowering because patients can see in real time the food that they consume, how it affects their blood sugar. And more often than not, most people would have absolutely no idea that the food that they're taking in is doing this to their system. So it's empowering for patients to see that in real time because it literally is in real time. You eat something and you look on your phone and you see your blood sugar.
Yes.
So it's very empowering for the patients. And it also allows me as the physician to help them learn where their blood sugar should be most of the times, and also help them understand that yes, your blood sugar is going to fluctuate, but on average it needs to be within that tight range. And that's what we use the monitors to do. It helps us show the patient what they're doing, and it helps us titrate their medication to get them in normal range.
Wow. Now, are there any other technologies that you are currently using in your practice to help to achieve this goal in addition to the CGMs or continuous glucose monitors?
Yes, I often employ insulin pumps, like daily insulin pumps. They are, it's called the Vigo, and it's a patch, and it's much like the continuous glucose monitor that you sort of install on your arm. You can install the insulin pump as well. And what that does, it is allows me to deliver a basal rate of insulin all day. And then I can also add insulin with each meal, by using that delivery device. And it's very helpful because that means that I can essentially take over the job of the pancreas for a little while.
That's a perfect transition because I was going to try to get that high level view with you. So the fact that you said that with many of these patients, you find yourself in the position where you're taking over the function of the pancreas. And then we have to begin to explore why in these patients' populations has the pancreas taken a vacation, gone on hiatus? Why are we seeing a prevalence or, a significant number of patients in these populations more so than if you were to look at other populations? Why are we seeing so many diabetics? And you could extend that to why are we seeing so many hypertensive? Why are we
Exactly.
seeing so many patients with end stage renal disease? I mean, I'm giving you a moment to reflect, to say, why are the patients that you treat so in such a dire condition that they need a patch that will give them continuous insulin to take over the function of the pancreas?
Right. Well, the answer is multifaceted, but one of the advantages of working at Adabo and a federally qualified health center is I actually have access to a lot of things that will help me attack some of those things that are causing this epidemic of diabetes. Primarily, the processed foods, fast foods are really driving the epidemic of diabetes. And we have to do a whole lot of education in order to help the patients understand how food controls their metabolism. And I have access at Adabo to a nutritionist, a social worker, and I've actually, in my clinic, I've been fortunate enough to have diabetic educators that have come to us to help us, because education is so much a part of what we're doing. And, we can talk about how medicine really doesn't afford us the opportunity to educate in the classic visit. So when I have the advantage of having a nutritionist, a diabetic educator, and a social worker to coordinate with me while I'm managing these patients, it's a multi-pronged attack on a disease that can complicate their lives. If we can control the blood sugar, and that's where I start first, if we can control the blood sugar, we can control complications. We can reduce the number of complications that patient will see. And that's where it begins.
Well, I think it's so fascinating because we're in this situation where there are habits that inform pathology in specific patient populations. And if we were to take a broader perspective, we say, oh, well, don't eat fast food, don't eat processed food. But if you're living in a food desert,
Absolutely.
and a food desert means you don't have access to healthy foods, you don't have grocery stores, you're dependent on what we call here bodegas or these mini marts, and you don't have fruits, vegetables, the whole foods type of market, then that is what you eat.
Exactly.
And so it is very challenging, I think, to look at the sequela. And I think similarly, if we were to go to hypertension, it's not the sugar, but the salt.
Right.
So we're essentially, by not having equity in access to healthy foods, we're perpetuating these diseases, diabetes, hypertension, and the after effects or end stages of these conditions. Tell me a bit about the population. What does it look like at your FQHC? And can that be extended to other FQHCs?
Yes, my population is primarily African American, Hispanic population. It is a food desert. It's a services desert. Everything is in short supply, unfortunately. But making the changes that we make has helped us lift up the community in a way that we as physicians probably didn't do traditionally in the past. But now we find ourselves in this position where we have to take that role, because in order to deal with the complications of these diseases, we have to get involved in these other aspects of their lives that directly affect their health. So,
Yes. What do you mean by that? Maybe you can give one specific example.
okay. So, you mentioned Whole Foods. And one of the things that I find in the population that I serve is there's a lot of, in addition to sugar, there's a lot of fat. And so, processed food is a big culprit. And getting people to understand that they need to cook at home, maybe go out of their way to buy things that are a little bit better for them, packing lunches instead of going through the drive-through, becomes a conversation that has to be had. And it means we're shifting the focus from medicine in the traditional sense to the promotion of health.
Yes, yes, which is so important and such a big part of why you went into medicine in the first place.
Absolutely.
And as we talk about that, the idea that you're assuming a role that maybe your predecessors did not take on, and that potentially the practice that you have now is not the practice that you envisioned when you started out.
Not at all.
I'm wondering if you could reflect on two or three changes that have occurred in medicine since the time you began.
Well, I find at least my time has been taken up in large part in advocating for my patients. And I never imagined that I was going to have to do that. And I'm not sure how every place does it. I can only speak for me and, at my office right now, I do fortunately have a little bit of administrative time that allows me to be an advocate for my patients. And usually that means calling up insurance companies and requesting medication, writing letters of medical necessity, asking a nutritionist or a diabetic educator to come in and meet with my patients because I don't get more than 15 minutes. They can actually sit down and have a conversation with them. That's what has to happen in a way that it wasn't happening before, or at least I didn't envision for myself.
Yes. Yes. And that's so fascinating that you're saying you need administrative time to deal with insurance companies
Yes,
and to bring on allies and allied health professionals to supplement or augment the care that you provide.
absolutely. I couldn't do it without them. And I'd love to, I mean, I don't know if I can say names, but but I mean,
Yes.
I would love to, if you would invite me back, I could bring some of the people that are on my team
Yes.
because
Yes.
I couldn't do it without them. I can't thank them enough because at this point, I am graduating some of my patients out of the high risk clinic. And when they started this process, I was worried about them going into renal failure. I was worried about them having a heart attack. And now I have these patients coming in with the medication that they need. Their blood sugar has normalized, their blood pressure has normalized. They want copies of their EKG, they want copies of their labs because they want to brag about that.
That's
And that is
phenomenal.
amazing.
Yes. Yes. And a testament to you, Dr. Ford.
Oh, thank
And
you.
and also a testament to the patients because
Absolutely.
I do think in some circles patients get written off. Oh, they don't have the potential to grasp
Right.
their medical condition, their medical care. They don't have the emotional bandwidth to become invested in turning it around. And the fact that you have these success stories that you can point to and that you're actually graduating patients out of the high risk clinic, that speaks volumes.
It's huge. And it's such an amazing thing. What I love to hear from my patients when they start off, they come to my clinic because they're high risk. That means their diabetes is not well controlled. Their high blood pressure is not well controlled. Their cholesterol is elevated. All of these things are risk factors to heart disease, renal failure, you know. So patients will actually say, as we move through the process of getting them normalized, they'll say, I never knew I could feel like this. I didn't understand, that I wasn't supposed to constantly have this pain or blurry vision or, all of these things that are literally complications of diabetes, high blood pressure, and high cholesterol.
Yes. And I, as we look at the overall theme of this podcast, the Journal of Healthcare's Race to the Bottom. When we look at the federally qualified health center, who's your number one payer? Is it Medicaid? Is it Medicare? Is it the Medicare Advantage plans? Who's your number one payer?
Um, it's Medicaid and Medicare by far.
And do you find that the reimbursements for the care that you provide are increasing, decreasing, or stable?
Decreasing, definitely.
So you're expected to bring on allied health professionals and to service high risk clinics, extending more time for less money.
Absolutely.
But as you and I both know, is the cost of medications increasing, decreasing, or going down?
It's increasing exponentially.
And the cost of the supplies that you use in your clinic, the drapes, the gloves, the medicines you may provide in the clinic by injection, are the costs of those things increasing, decreasing, or staying the same?
Increasing.
So we're expected to deal with all of these assets, which are subject to inflation, But actually, we're in an environment where if we're dealing with a government payer, we're experiencing deflation. Our value has gone down.
Oh yes. It is challenging, and one of the things that this clinic has attracted the attention of some corporations who are happy to partner with me to
Yes.
try and do this. And that has been a saving grace because the medications, the technology, I would not have access to that if I didn't have those partnerships. And it is incredibly valuable.
So you're able to have partnerships because I guess in some way these companies are able to continue to make a profit
Right.
for the product that they are marketing for as a medication or a treatment. So we're essentially saying we need a public private partnership in order to sustain the level of care that is required for these high risk patients.
Yes, that's the way we've been able to make it work. I
And
mean,
without that public private partnership, would you be able to make it work?
no, absolutely no.
And so the question is this a sustainable model? This is why this podcast is entitled what it is, because, we're experiencing, again, this boomer population. We're not quite out of the boomers graduating into Medicare age. So that number of patients is increasing. I'm not really sure what's happening with the government assisted patients who are not of Medicare age, who are on Medicaid, but certainly the population is not shrinking. And yet the payments, and again, I posted on LinkedIn that of the percentage of budget, it's greater than 50%. I think it was like 58%, the combination of Social Security as well as Medicare. So the budget percentage is significant, more than half, but yet it's still not enough. And per person, it's not enough, to the extent that you have had to sort of get on your ingenuity train to find your own solution, which is a public private partnership.
Right. I mean, it is downright near impossible without that. The company that makes the continuous glucose monitor, the company that makes the insulin pump, the company that gives me the injectable medication for reducing cholesterol, they're wanting to partner with me because the data that demonstrates that we can get a patient from non controlled to controlled is valuable to them. That's why they're interested in my population. They're not interested necessarily in, being of service. I don't want to say that. But this is a small drop in the bucket for them. It provides them with data and information that is valuable for them that they can then market when they are going to try and get their next generation device, medication on the market.
Yes, this is fascinating and so enlightening. I think, we're going to begin to wrap things up, but what I wanted to ask is just the hypothetical. If we want this system to survive, before, say, it's broken and we can't, rescue any part of the system. If we want this FQHC system to survive, then should we be looking for states and the federal government to begin exploring more of these public private partnerships for funding?
Absolutely. One of the things that I think, especially in the Northeast, where we happen to be an area that There's lots of medical technology companies. We need to have those under state sponsorship, federal sponsorship, so that these patients can access them without having to be at the mercy of, the formularies of their insurance companies. Because I can't tell you how many times I've had a patient who's been able to get to goal, and then their insurance company changed the formulary and their medicine is no longer covered.
Right. So you have a patient who's in your clinic who has started a medication, is seeing the benefits, and then the beginning of the year rolls around or whatever date the insurance company chooses, and it's no longer formulary. So it could cost them thousands of dollars a month to keep up with the treatment that you've designated that they really need.
Yes.
So we see that the challenges are just that we've explored briefly threefold right now. We have the environmental challenge
Right.
of the food deserts and the lack of access to healthy food and healthy ideation around the concept of food and nutrition
Hmm.
without blame placing or
Right.
blame
Of
sharing.
course.
We're just stating facts. Then obviously that leads to disease. So then we have the issue of patients who are accessing healthcare through government assistance, be it age related or finance related, who are seeing that the amount that the government is paying for their care does not cover the cost of their care.
Correct.
And then lastly, we're seeing that insurance companies, in order to increase the profit to their shareholder, become selective with formularies independent of the benefit to the patient. Have I summarized that clearly?
Perfectly. So it is challenging every day. And none of those challenges look like they're going to get better unless we co-opt some of this under the federal government, state government, so that we don't have part of that problem.
Yes.
I
Yes.
don't I don't see it changing
Yes,
unless that happens.
we have to sort of bridge that purely capitalist view, especially where insurance companies are concerned, and begin to look at the bigger picture, because we can't just continue to focus on profit to shareholders when we're in the position of rationing care
Right.
from an insurance perspective. And that could be a federal insurer or it could be a private insurer.
Right.
Dr. Ford, I leave it to you to give some closing words, thought leadership to our audience on UpMed, the Journal of Healthcare's Race to the Bottom.
Well, hope springs eternal. And I think we've spoken about ways that we think we can solve this problem. This is novel. What we're doing is very novel. I'm internally hopeful. I think if you want to do, especially primary care medicine these days, you have to look at yourself as an advocate equally as a healer. so so
Yes.
servant leadership.
Yes, both. Yes, yes. Right on, sister. Right on. That's what it takes just to stay in the game, right? Not to
Right.
get burned out with all of the demands and the pressures. You have to be optimistic. You have to be dedicated to the higher goal of patient care and not so caught up with the limitations of your current system, and even somewhat of a vanguard, a very assertive person as you are, to find the money,
Right.
because the money is out there. Find the money for the patients and do what you can to graduate patients out of high risk clinic.
Absolutely.
Well, thank you so much, Dr. Ford, for joining me on this beautiful day to talk about the woes and the joys of healthcare on UpMed, the Journal of Healthcare's Race to the Bottom. I'm your host, Dr. Erica Rowe Urquhart. We'll see you next time.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's race to the bottom.